Hello, today we will be doing the VAP Voice Assessment Protocol. Included in the box is a voice assessment protocol for children and adults manual and its respective protocol. The purpose of the VAP is to assess 5 parameters of the voice: pitch, quality, loudness, breath features, rate, and rhythm. Voice cases are traditionally the lowest on a speech pathologist's caseload. The voice assessment protocol was devised to organize and guide the diagnostic decision-making process. The voice assessment protocol differs from other evaluation forms in the interpretations of normalcy are facilitated by the Likert scale or grid marking system. A Likert scale is commonly used in research that employs questionnaires. Scoring procedures rely on a good clinical ear. Information necessary to place the client on a normal to abnormal spectrum is provided directly on the protocol. The assessment may be completed without sophisticated instrumentation. The materials necessary to complete the protocol include pencil, tape recorder, stopwatch, and a good clinical ear. Perceptual judgments, while more than adequate, may be supplemented by any variety of instrumentation. These include piano or other musical instruments, pitch pipe, sound spectrograph, and loudness indicators. The assessment form should provide the clinician with a structure for critically listening to each parameter of the client's voice. The voice assessment protocol, being a pre-listed form, ensures that deviations are not overlooked. Care must be taken to appraise a variety of dimensions within each of the 5 vocal parameters: pitch, loudness, quality, breath features, and rate and rhythm. Decisions regarding each dimension are to be marked on the protocol's grid, thus supplying immediate information about the vocal normalcy. Areas of deficit emerge with predominance of markings in the abnormal range of the grids. A sample of speech is necessary to judge auditorily the normalcy of the voice. Ideally, this should be a conversational sample supplemented with phoneme prolongation tasks. These may include singing the scale, diadodokinetic testing, reading, and similar tasks of one's choosing. A high-quality tape recording of the voice should be saved for reliability ratings. While listening to the client, an overall judgment of the voice is insufficient. Each parameter of the voice must be judged independently. The first section of the protocol is the pitch. It is beyond the scope of this protocol to discuss methodology issues regarding habitual pitch and optimal pitch. Appendices B and C summarize popular techniques. The protocol calls for a piano or keyboard with frequency equivalencies. We will be using an app today. To determine the client's habitual pitch, we will have them count to 3 and hold the E sound at the end. The app we use then recorded the hertz. To determine if the pitch was appropriate for the client's age, sex, and stature, we compared it to a normative chart of average fundamental frequencies and normal limits. Using the app, we recorded the highest and lowest pitch ranges of a random speech sample. To record the optimal pitch in hertz, we use the method called loud sigh technique. Normal voice is characterized by variability in pitch, known as intonation or inflection. Linguistic emphasis and linguistic meaning are expressed using pitch variability. The voice is abnormal when there is a lack of pitch variability or when pitch fluctuations are excessive. Dysarthria may be characterized by monotone pitch where a limited range of notes is used. Pitch variability can be heard in particularly spastic, ataxic, and hyperkinetic forms. If diplophonia is present, it should be noted on the protocol. Diplophonia refers to the presence of 2 or more spontaneous pitches in voice. These multiple tones are produced by separate or unequal vibration sources. A frequent cause is one paralyzed vocal cord vibration at a different rate than the healthy fold. Pitch breaks most often occur in a person using inappropriate low-pitch voice. If pitch breaks are observed in a client, Their presence and direction should be noted on the protocol. Any condition that adds to the mass or size of vocal folds may alter their vibratory characteristics. Pitch breaks, if they occur, are more frequent during the final phase of puberty and should be of no consequence. We should take note if pitch breaks occur, and if so, in which direction do they go. The clinician will now go through the pitch assessment.
Okay, so today we're going to do a voice assessment protocol. This is going to be a test that's assessing your voice and the loudness, the quality, any breath features. So it's going to be pretty simple. And are you ready to start?
Yeah.
Okay, so the first thing I want you to do is I want you to count to 3, and I want you to do it after me, okay? 1, 2, 3, and hold the E sound, okay?
Okay. 1, 2, 3.
Good job.
By counting to 3, we obtain the client's habitual pitch.
Okay, so the next thing is, what did you do today?
Had breakfast. I walked outside.
By obtaining a random speech sample, we can determine the pitch range.
I got to spend time also with family.
Okay.
Yeah.
Did you see anything when you were outside?
Saw a lot of trees. I got to see a lot of birds. People were walking their dogs.
We then use the loud sigh technique
So the next thing
to
I want you to do is
determine
I
the
want you to take
optimal
a deep
pitch.
breath in, and then when you let out the air, I want you to go ah like this. Ah. Okay. Ready?
Yeah.
All right.
The pitch variability obtained from the random speech sample was normal. There was no diplophonia present or pitch breaks. During the assessment, we will determine whether the loudness is appropriate for speaking situations. In normal conversational speech, from a distance of about 3 feet from the speaker, the average sound intensity is between 55 to 75 decibels. These observations should be marked on the grids of the protocol. The clinician also should note if the typical loudness level can be maintained comfortably. Observe whether excessive tension and strain are used to drive the respiratory laryngeal systems. Phonation breaks or momentary skips of loudness are abnormal and may indicate difficulty maintaining vocal fold adduction and vibration. A certain amount of loudness variability is normal. Loudness variability is reflected as differential stress patterns. Lack of loudness variability may take 2 differing forms of monoloudness. These should be noted on the protocol. The clinician may wish to have the client demonstrate his or her range of usable loudness from soft to maximum levels. Restricted loudness ranges are often seen in clients with respiratory involvement, particularly dysarthria. Loudness may be affected by supraglottal events, limited movements of the anterior articulators affecting a small degree of mouth opening or obstruct vocal radiation. This reduction in loudness may be detrimental to clients such as those with dysarthria, who may already have difficulty with slurring and imprecise articulation. These and similar observations should be noted on the protocol. Space is provided on the protocol to describe daily use of the voice and situations of abuse. We will now watch the clinician assess loudness through a random speech
Do you
sample.
like Halloween?
I do. It's actually my favorite holiday.
It is?
Yeah.
Why is it your favorite holiday?
I love doing the different activities. I watch movies, I carve pumpkins, I spend time with my family and friends. We make cookies, we bake Halloween cookies.
Sounds yummy.
Yeah. I'm trying to think, what else do we do?
Are you going to be dressing up this year?
Throughout the speech sample, the clinician is looking for typical levels of loudness, the degree of effort, if loudness trails off at the end of an utterance, phonation loudness, the rate of loudness variability, and if loudness ranges from soft to maximum levels.
Really
The
cool.
Dalmatians, yeah, there's like 100 of them.
Yeah.
Maybe more?
I think 101.
Maybe 101.
So you said you liked Halloween movies. Which one's your favorite?
Ooh, that's a hard question. Maybe Halloween Town?
Halloween Town?
Mm-hmm.
Which one of the Halloween Towns do you like?
They're all really good. If I had to choose, I would say the first one.
The first one?
Yeah.
Yeah, the original's the best.
Yeah, I think, the character's name, the first one? Marnie, she saved Halloween Town.
Yeah, with her sister and mom and grandmother.
Yes.
Yeah, and brother.
And brother,
Yeah.
all of them.
So did you carve any pumpkins in this house?
I did.
Really?
It's not scary. It just did a happy face.
That's good. Nobody likes scary pumpkins.
No, I don't like too many scary things.
For the quality assessment, we are looking at breathiness, harshness, and hoarseness. Breathiness may be due to an obstruction by mass or lesion, a paralyzed cord, or muscular incompetence. Harshness might be perceived as roughness and unpleasantness when applying effort and force on the vocal folds. Hoarseness is a combination of breathiness and harshness that is recognized by clinicians, which requires familiarity with vocal abuse and related lesions that are a sign of auditory symptoms. Also addressed in the quality assessment are glottal attacks and resonance. Glottal attacks refer to the strong impact in the initiation of speech and the extra effort needed to start the vibrations of the vocal folds that are tightly abducted. Before phonation, there is a great amount of tension in the laryngeal muscles. Weak glottal approximations are soft attacks and lead to breathiness after phonation. Resonance is the effect of vocal quality that can be understood as hyponasality, hypernasality, nasal emission, or cul-de-sac resonance. It affects the pronunciation of the n, and ng, as well as production of other consonants. Breathiness, harshness, and hoarseness are all rated as severe and distracting, moderate in degree, slight or intermittent, or not present at all. Glottal attacks can be described as too abrupt, hard glottal approximations, normal glottal closure, or too soft, weak approximation. Resonance on vowels and vocalic elements will be rated as severe hypernasality, moderate excessive nasal resonance, or slight, intermittent, or assimilative nasality. On pressure consonants, it will be rated as moderate to severe nasal emission or slight or intermittent nasal emission. Normal resonance balance can fall into cul-de-sac oropharyngeal resonance, slight or intermittent denasality, or moderate to severe hyponasality. To assess the quality of the client's voice, she will be reading the grandfather passage. It is a public domain text frequently used to gather a speech sample. It contains nearly all the English phonemes of American English.
Work on your quality, okay, your voice quality. So what I'm going to have you do is I'm going to have you read this passage. It's called the grandfather passage, okay? I want you to read it out loud, take as much time as you need, and if you have any questions or need help, let me know, okay?
You wish to know all about my grandfather. Well, he's nearly 93 years old. He dresses himself in an ancient black frock coat, usually minus several buttons. Yet he still thinks as swiftly as ever. A long flowing beard clings to his chin, giving those who observe him a pronounced feeling of utmost respect. When he speaks, his voice is just a bit cracked and quivers a trifle. Twice each day he plays skillfully and with zest upon our small organ, except in the winter when the ooze or snow or ice prevents He slowly takes a short walk in the open air each day. We often urged him to walk more and smoke less, but he always answers, "Banana oil." Grandfather likes to be modern in his language. Is that okay?
That was perfect. Good job.
Awesome.
Breathing variables affect vocal loudness and rate of speech. Regional predominance, associated noise, words per breath, maximum phonation time, S and Z ratio are being assessed. In regional predominance, the diaphragm is the principle of inhalation and various thoracic muscles assist when needed. It can be difficult to observe while the client is sitting. Make sure that there is expansion of the chest, not shoulders. Make note if they have clavicular breathing. The predominant region of breathing will be scored as clavicular, poor breath support, thoracic acceptable, or diaphragmic preferred. Noise during breathing is considered severe and can be the result of vocal fold paralysis or dysarthria. The sound, if noticeable, will be rated as severe obvious inhalatory stridor, slight to moderate audible inhalation, or no sound heard, normal. Obtain a random speech sample or have the client read a passage to count how many words the individual says between each breath and record the number in the protocol. Less than 7 words is considered poor breath, and about 7 to 13 is normal. More than 13 is excessive. To obtain maximum phonation time, a stopwatch is used to time how long they can prolong phonating the sound ah. The client should have multiple attempts with deep breaths in between, and the longest phonation should be recorded. Phonation time of less than 6 seconds is a sign of respiratory phonatory problems. The S and Z ratio requires a stopwatch to time the phonation. The client is given 2 trials for the prolongation of voiceless S and voice Z phonemes. Both are recorded and the best results are put in the protocol to calculate the ratio. If the S-Z ratio is greater than 1.2 for the child or 1.4 for the adult, laryngeal pathology may exist. Let's take a look at how the clinician tests breath features.
Okay, so the next thing I'm going to have you do is I want you to just read this passage in your head, okay? To yourself.
Okay.
I'll tell you when to stop. You don't have to read the whole thing.
Okay.
As the client reads the passage in their head, the clinician is looking for the predominant region of breathing and any sounds associated with breathing for speech.
Okay, you can stop.
Okay.
Okay, so the next thing I'm going to do is I'm going to ask you some questions, okay?
Okay.
So do you do any activities after school?
I do. I dance. My friends and I do dance.
With this random speech sample, the clinician is trying to assess the number of words per breath.
Before my mom picks me up.
Awesome. What kind of dance do you do?
Ballet and jazz. In ballet, we get to wear nice little tutus. Mine's is pink. And we have a show at the end of the year for it. And the other one is jazz. But I don't like jazz as much. I like ballet more. Yeah. We're doing a Christmas show with ballet. We're doing the Nutcracker.
That's so nice.
Yeah.
Okay. So the next thing I'm gonna have you do is hold the sound ah, but just give me 1 second, okay?
The client should be able to hold the ah sound for more than 9 seconds to be considered
I
normal.
want you to say ah for as long as you can, okay?
Okay.
Okay, ready, set, go. Good job. Okay, so the next thing I want you to do is I want you to do the s sound for as long as you can, okay? Ready, set, go. do that one more time, okay?
Okay.
Go.
The S and Z sounds are recorded to create a ratio.
And the next thing I want you to do is I want you to do the Z sound. Zzz, okay? Hold that for as long as you can, okay? Ready, set, go.
Greater than 1 to 2 ratio suggests laryngeal pathology.
Ready, set, go.
A 1 to 0 suggests normal larynx.
Perfect.
The rate at which a client talks should be assessed and can affect the variables of speech and voice. Let's take a closer look at rate of speech and diadokinesis. For rate of speech, we'll count the number of words recorded in a span of 60 seconds. An alternative method is having the client read a passage with pre-numbered words. Diadokinesis is the repetition of p, t, and k as fast and evenly as possible. Time the client and see how long it takes them to complete 20 single-syllable repetitions. After they have completed the p, t, and k, have the client do 10 trisyllabic repetitions, p-t-k. The client should be instructed to complete these tasks as clear and fast as they can. For rate of speech, if the client tries to say too many words in one breath, it may be Parkinson's or cluttering. Cerebral palsy or Parkinson's may interfere with the rate of speech and control of speech. For diadokinesis, imprecise articulation may produce sounds of continuous blur. The clinician will now score the rate and rhythm portion of the protocol.
Okay, so I'm gonna have you read another passage, okay? I want you to read it out loud and keep reading until I tell you to stop. If you finish the passage, just reread it again, okay?
Okay.
Thank you.
Okay.
Ready, set, go.
When the sunlight strikes raindrops in the air, they act like a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors. These take the shape of a long, round arch.
The clinician is obtaining the rate of speech during conversation for 1 minute.
And its two ends apparently beyond the horizon. There is, according to the legend, a boiling pot of gold at one end. People look, but no one ever finds it. When a man looks for something beyond his
Stop.
reach.
Good job. Okay. So the next thing I need you to do is repeat after me. You're gonna say puh.
Puh.
Good job. Okay, so I need you to say it as fast as you can until I tell you to stop. Okay?
Okay.
Ready, set, go.
Puh, 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 puh.
Stop. Good job. All right, now I need you to do, can you say tuh?
Tuh.
Good job. So I need you to say tuh as fast as you can, okay? And keep going until I tell you stop. Ready, set, go.
Ta 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 ta.
Stop. Good job. Can you say cuh?
Cuh.
Good. Now I need you to say that as many times as you can, or as fast as you can, okay?
Okay.
And stop when I tell you to stop. Ready,
Okay.
set, go.
Ka 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 ka.
Stop. Good job. All right. So can you put all of those sounds together like pataka?
Pataka.
Good job. All right. Now I need you to say that as fast as you can. Okay, and stop when I tell you to stop. Ready, set, go.
Patika, 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 patika.
Stop. All right.
This concludes the voice assessment protocol for children and adults.